Now see this case. A 60-year-old female, non-smoker, diabetic, hypertensive and dyslipidemic without any previous chest pain, presented with chest pain. Now what is the differential of this thing? She is diabetic, she is hypertensive, she is dyslipidemic. What are the differentials? So the top differential would be ischemic heart disease, angina pectoris. Now this is the first episode of angina. What would you call it technically? If it is, we see this angina or not. So what would you call it? Unstable angina. A recent onset angina is unstable angina. Esophageal dysmotility can cause chest pain. Aortic dissection, one very serious medical emergency that can cause chest pain. Pulmonary embolism, again very serious emergency. Pericarditis, not that acutely very serious until there is tamponade, pleurisy, tracheitis, musculoskeletal pain, and in the end there is a functional pain. So these are the different differential we can have in this patient. Now we see the data a little further. She has chest pain and tightness and severe shortness of breath. Now our differential list should be edited. Would it be edited or would it remain the same? So it would change. Again on top you got coronaries, pulmonary embolism, pneumothorax, pleurisy, tracheitis. So these may be our differential, and you can include sometime if the patient is young, very apprehensive, functional disorder. Otherwise the top three are to be considered. Pleurisy does not usually present with a lot of shortness of breath, and so does tracheitis. Now we add a few more things. She had severe shortness of breath for last 10 minutes. Problem started a month ago, pain coming with exertion. One day before admission, she was severely dyspneic and distressed. Drug history only, non-steroidal anti-inflammatory drugs. On CCU admission, she was fully conscious and oriented. Now, what is your diagnosis? Now, we can further contract the diagnosis. What will be the diagnosis now? Angina pectoris. You got multiple risk factors now: diabetes, hypertension, dyslipidemia, the character of pain, relation with exertion, shortness of breath. Why this patient has become short of breath? One of the coronary artery is occluded, the blood supply is compromised. That portion of the myocardium is not getting enough oxygen and glucose. So not getting enough nutrients to contract. So that portion of the myocardium will not be contracting very well. So that means the heart is on overall, the LV is not contracting. So that will result in diminished output from the LV. So that means back pressure will start increasing. So patient will have shortness of breath. Second reason is that if the chordae tendineae, the muscles supplying the chordae tendineae, the papillary muscles, they become ischemic, they will not contract properly. So when you have the opening and closure of the valve, these muscles actively contract and keep the valve in their place. If they are not contracting well, that will result in mitral regurgitation. So the patient may have transient mitral regurgitation. So that's what produces the shortness of breath. Now the diagnosis is angina pectoris. Ischemic heart disease can be divided into two main type of syndromes: chronic stable angina and acute coronary syndromes. Symptoms occur with physical exertion, eating, exposure to cold, emotional stress. For example, hurrying across a street or climbing a long stairs. It's due to greater demand of oxygen which the heart can supply. And the second is acute coronary syndrome. Obviously, as the name indicates, presents with acute onset of symptoms. It is divided into unstable angina, non-ST elevation MI, and ST elevation MI. This we will deal tomorrow. This ACS or acute coronary syndrome, we'll see tomorrow morning. Now we see this chronic stable angina. Now what are the risk factors present in this patient we saw? Patient is diabetic, hypertensive, dyslipidemia, age, 60 years is really a very old age. In females before the age of 55, the incidence and prevalence of ischemic heart disease is much less as compared to males, because the female hormones, they protect against this disease. But after 55 years, the incidence starts increasing and starts matching the males. So these are the risk factors present in this patient. Now, what are the risk factors in general for coronary artery disease? We, for sake of simplicity, divide them into two. One is non-modifiable, which we cannot modify. So age, the gender, the family history, the previous history of myocardial infarction, stroke, or peripheral arterial disease cannot be modified. But these are modifiable factors like diabetes, hypertension, smoking, dyslipidemia, lifestyle, weight, stress. Why diabetes on the top always? Type 2 diabetes, not type 1. It's the type 2 diabetes which is more important. The patients with type 1 can also have coronary artery disease, but it's the type 2. Why type 2? You see, type 2 is also called ischemic heart disease equivalent. If a patient has type 2 diabetes and a patient has no diabetes but one episode of myocardial infarction, the chances of having another episode of ischemic heart disease in these two patients is same. So a type 2 diabetic is presumed that he already has one MI. So if a patient has one MI once and a type 2 diabetic who does not have an MI, both of them have similar chance of having an episode of acute MI again. So it's called ischemic heart disease equivalent. So it's very serious. So patients with type 2 diabetes tend to have very high chances of coronary artery disease. In fact, patients who got impaired glucose tolerance or impaired fasting glucose, you know that term? If the fasting blood sugar is between 100 and 125, or the postprandial between 140 and 200. So these are patients who got impaired glucose metabolism. Even they are at high risk of ischemic heart disease, even without being frankly or overtly diabetic. So this has to be taken very seriously. Since in our population, the diabetes, type 2 diabetes is increasing, the natural consequences that ischemic heart disease will also increase. Now, our pathophysiology is simple. You know it. There is a mismatch between supply and demand. Resulting anaerobic metabolism leads to impairment of metabolic, mechanical, and electrical functions. So you can have all problems. Metabolic dysfunction, there is accumulation of acids in the myocardium, because anaerobic metabolism leads to lactic acidosis. There's poor contraction and the electrical activity may become abnormal. So all these things can happen when there is ischemia. Adenosine is the most probable candidate for pain production. Now, what's the definition of angina? And remember, the diagnosis of angina in most of the cases is clinical. If you take a good history, you can diagnose that this patient has angina. In some patients, we need investigations. Recurring acute chest pain or discomfort with following features. So it may not be pain, it may be discomfort. It has a relationship with activity. It comes on exertion, improves with rest. There is sensation of squeezing, strangling, heaviness, suffocation. So all these feelings can be present. Patient may have shortness of breath. The reason already told you, patient may have autonomic features, nausea, vomiting, sympathetic discharge, cold sweating called diaphoresis. The patient says that I have cold sweat on my forehead and I feel pretty weak. Radiation to multiple areas, left arm, maybe it's right arm as well. Shoulders, neck, jaw, upper abdomen, on the back between shoulder blades. So these are different areas. The pain can radiate, or in fact, it may be appreciated only in these areas and may not be appreciated in the chest. So whenever there are risk factors your examination is disproportionate, and you have pain in areas of reference, consider presence of ischemic heart disease. Improve with rest and sublingual nitrates. Now, how do we stage angina? We saw this when we're doing the symptomatology. Class 1 angina, angina only during strenuous or prolonged physical activity. Class 2, slight limitation in physical activity, the angina only during vigorous physical activity. Class 3 is symptoms with everyday living activities. There is moderate limitation, and class 4 is severe limitation. Inability to perform any activity without angina, or even at rest angina. Patient tries to change the shirt, starts having angina. So this is one severe form of angina. Physical examination, what do you find on physical examination in patients with angina? The examination may be unremarkable. Look for the presence of signs of hypertension. Where would you look for the signs of hypertension? You just check the blood pressure and look for the signs of chronic hypertension. Where would you look? So look for the presence of signs of diabetes and hypertension. Where do you look for the signs of hypertension? You look into the eye, fundal examination. Are the changes of chronic hypertension there or not? Examination of the heart may not be very reliable in patients with setting of angina, because you may hear a fourth heart sound during angina as well. Now, what is this? Look for the additional causes of, secondary causes of heart disease, like aortic stenosis. Aortic stenosis can cause angina even with normal coronary arteries. This is Levine sign. The patient presents with this appearance, and this is nearly diagnostic that this is a coronary event. Angina or infarction, whatever, but this is the classical presentation. Look at the agony on the face, hand placed in the center of the chest. Patient don't have a pointing sign. The hand is placed across the chest. The patient cannot tell where is the problem. Something gone here. Look for the evidence of dyslipidemia in the eyes, the tendons and thomas. Third or fourth heart sound may be audible during an anginal attack. When the angina resolves, they disappear. And you may have a transient murmur of mitral regurgitation if the patient has involvement of the mitral valve apparatus. So this may be present on physical examination. Now, chronic stable angina is divided into various types, like exertional variant angina equivalent syndrome, silent ischemia, prinzmetal angina, syndrome X, and decubitus angina. There are a few other terms used for angina. They are uncommon, so that's why I have not mentioned those terms. Now, the classical exertional angina. Coronary artery obstruction is not sufficient to result in resting myocardial ischemia. The obstruction is not enough. At what level of obstruction do you start having symptoms? 70%. So it means when the symptoms are there, already a lot of damage has been done. When myocardial demand increases, ischemia results and the patient has symptoms. So this is the classical exertional angina. And then you may have a variant angina. Chest discomfort, pain at rest with transient ECG changes and with a prompt response to nitrate. It can come at rest and disappears. You see, myocardial infarction comes at rest but does not disappear. Transient impairment of coronary blood flow by vasospasm or platelet aggregation, which tends to settle down sometimes on its own. Sometimes it can be brought by anxiety. Majority of patients have an atherosclerotic plaque underlying. Angina equivalent syndrome. Patient may not have pain. Patient may have atypical symptoms, which are because of this. Patients with exertional dyspnea, exertional dyspepsia, discomfort rather than exertional chest pain. So you see, if the patient says, I have problem when I eat and start walking, I have trouble in the epigastric area, this may be angina, particularly if the risk factors are present. So always evaluate risk factors. Sometimes people may not have obvious risk factor. For example, they may be impaired glucose tolerance, which may not be detected in some patients. Some patient may not be aware of their diabetes status or hypertension status, caused by exercise-induced left ventricular dysfunction. Silent angina. What is silent angina? Silent angina means patient does not have any symptoms. So you confuse between angina equivalents and silent ischemia. In angina equivalent, patient has some symptoms, albeit they are atypical, may have shortness of breath, or patient may have dyspepsia or discomfort. A transient alteration in myocardial perfusion in the absence of chest pain or the usual anginal equivalents, so patient doesn't have any symptoms. These are more serious things which can produce consequences. Even sometimes the medical professionals do not recognize it. It's difficult to diagnose condition. Holter monitoring may be required, exercise testing may be required to reach to conclusion what's happened. Then Prinzmetal angina, spasm of a large coronary artery, produces transient transmural ischemia. So angina usually does not produce transmural ischemia. Transmural ischemia is seen in ST elevation MIs. So this is another condition in which there is a transmural ischemia, but this is transient and reverses. ST segment elevation or at rest or with exercise, not a common disease. And then in syndrome X, what is typical exertional angina with positive exercise tolerance test? Anatomically normal coronary arteries. Coronary arteries are normal. When you do an angiogram, you find the coronary arteries are normal, but there is problem at the microvasculature. The prognosis generally is good. Decubitus angina, when the patient develops angina and lying down. Why the angina and lying down? The angina should be on exertion. Why the angina is on lying down? So venous return increases. That means the heart has to contract more forcefully. As the heart dilates, as per Frank-Starling law, it contracts vigorously. So it can produce angina. So this is seen in patients who have fairly advanced disease. Now diagnosis is most of the time clinical. This is another presentation. Patient feels very weak and patient tends to sit. When the patient is standing, patient may be more symptomatic, they tend to sit down. Diagnostic test, ECG, is usually normal between the attacks. It may show some transient changes like T-wave inversions, sometimes appearance of U waves or ST segment depression. So you may find these features during an attack, otherwise ECG may be normal. These are different type of depressions. The horizontal depression, this is upsloping depression. Stress ECG testing, it may be on treadmill, stationary bicycle, or you may use pharmacological testing when the patients cannot walk or exercise, have got knee joint problems, they cannot do a bicycle ergometer. So you can use pharmacological stress. Which pharmacological stress can be used? Dobutamine can be used. Why dobutamine? It's both inotropic and chronotropic. It increases the force of contraction. That means it is going to increase the myocardial wall stiffness. So that means the myocardium will be requiring more oxygen. So if angina is there, it will be precipitated. Then you can, with the stress, you can see on ECG. There are changes in the ECG. You can also use nuclear scanning like thallium scan. Echocardiography can also be used during pharmacological stress. So all these modalities can be used when you are giving the patient stress and see what are the changes in ECG or thallium scan or the echo. Then you can go for a coronary angiogram. You can use CT angiogram and CT calcium scoring. You can do, through a software, you can do a CT scan which can give you the anatomy of the coronaries, and it can also tell you how much is the calcium in the coronaries. Calcium indirectly indicates the atherosclerotic plaque because the plaque is generally degenerated in the center and calcium deposits in there. Or you can go for conventional angiography. So what would you choose, CT angiogram or conventional angiogram? The negative predictive value of CT angiogram is more, but this is the gold standard. So if you got features very suggestive that this is angina, go straight for conventional angiogram because you can go for intervention at the same time. If you want to place a stent, you can go for blood tests, lipid panel, hemoglobin A1C, blood sugars, CRP, that might be useful. Proteinuria, if it is present, it's a risk factor for developing coronary artery disease. Now the goals of treatment are improve the quality of life, reduce the mortality due to coronary artery disease progression. Stop smoking, diet low in saturated fat and cholesterol, aspirin, weight loss, stress management. How can you manage stress? Treat risk factors like diabetes, hypertension, dyslipidemia. Drug therapy. The drug therapy for heart disease are only for symptomatic improvement. Which drugs can modify the long-term prognosis of coronary artery disease? Yes? Dyslipidemic treatment, that is statins and aspirin. These are symptomatic treatment. Nitrates, beta blockers, calcium channel blockers. How do nitrates work? They decrease the venous return. So LV cavity size decreases. Beta blockers, calcium channel blockers, they are negative inotropic drugs. So they decrease the myocardial wall stiffness. Contraction is decreased. So they can reduce the symptoms. Potassium channel activators, they are newer drugs. Potassium channel activators and calcium channel activators blockers are generally not used. These are the first drugs, nitrates and beta blockers. If the patient do not tolerate or patient need additional drugs, we may add these drugs. Other treatment options are percutaneous intervention. If there is one or two vessel disease with normal LV function, we can go for percutaneous intervention. That is, we place in stents. CABG, coronary artery bypass grafting. If the patient has left main stem disease, 3 or more vessels and LV dysfunction, the better choice is CABG. And you have to see if there are no contraindication for CABG. For example, the patient may have certain contraindication for CABG because this is an extensive surgery. So if there are contraindications, sometimes we choose even in these patients not in this left main stem. Otherwise, we may think of passing stents in other situations as well if the patient is not suitable for surgery. Transmyocardial revascularization, what is this? This is a new modality, not very frequently used. If you make a lot of holes in the myocardium, if using the laser you produce a lot of holes in the myocardium, the surface area of the myocardium will increase, the contact of blood with the myocardium will increase and oxygenation may improve, but this is not really a very good option right now. I don't think this will be very useful. Series of transmural endomyocardial channels are created to improve myocardial perfusion. So when you can do nothing, you may think of this thing. So I think this is the last slide. Stem cells. CD34 positive stem cells induce neovascularization in ischemic myocardium, may enhance perfusion. These stem cells are under investigations. They are not really approved. Now this patient was diagnosed with angina. She was started on carvedilol, it's a beta blocker. Captopril is an ACE inhibitor. Aspirin, atorvastatin, omeprazole. Why omeprazole? Because of this thing. Omeprazole is not for stress, for acid. She was put on multivitamin. lactulose for constipation. So these were the treatment given to this patient. So any questions for this?